Welcome. I'm Michelle Cowles. I'm the Director of Business Development at Rogers Behavioral Health. I will act as your moderator today. Joining me is Dr. Martin Franklin, Clinical Director of Rogers location in Philadelphia. Dr. Franklin is an expert in the assessment and treatment of OCD. Before we get started, I want to give you a quick overview of the format. The webinar is scheduled for 90 minutes. And we are recording it, so we'll be able to share the link later. It will be on our website where you signed up for the webinar. Dr. Franklin will give a 70 to 75-minute presentation. Following his presentation, I will facilitate a Q&A. So if you'd like to answer a question on the Zoom bar, there's a Q&A bar, and we'll get to as many of those as we can. I'll just review them, and then Dr. Franklin will address them during the Q&A portion of the website. And now I'd like to turn the presentation over to Dr. Franklin.
All righty, thank you, Michelle. Hello, everybody. Customarily, when I'm talking to 1,000 people, I have some feedback. These days, I'm just looking at a camera. I'm getting used to that myself. So I apologize in advance for any of the clunkiness. So let me start by talking about our topic. We're treating OCD during COVID-19, which is proposed both unique challenges and also opportunities. So I'm going to really get into that today in quite a bit of detail. This is a disclosure slide, published a recent manual on the treatment of pediatric OCD specifically, but my career is expanded across the entire developmental spectrum. I treat kids, I treat adults, treat all sorts of people with OCD and related conditions, and we'll talk about OCD specifically, but we will include examples from both kids and adults as we go. So, our learning objectives today, these are the kind of things we're going to try to leave you with when you finish up, that you can talk about the ERP, essentially the key components of treatment, adaptations that you may need to make, especially in the context of telehealth, which I'm going to spend some time on, and also talking about specifically with families. There's some challenges to treating families that are unique, and sometimes I think what it really comes down to is how do you balance recognizing the kid's need to do this treatment independently with also addressing family-related matters, especially a combination that can influence and affect symptoms negatively. So we have to find some way to work it out so the kids are in charge of the treatment, but the parents are involved to the extent that we need them to. That's true even when they're treating live, but I think it's a unique challenge when we're treating remotely and we're not quite sure sometimes who's in the room, and we have to really address some of those etiquette issues so the kid feels comfortable and can express themselves, but also the parents feel like they have access to the treatment as well. Okay? So these are things we're going to get into. Maybe I'll not belabor these. They're on your slide set. I'm going to actually launch into talking about this stuff. So across the developmental spectrum, exposure plus response prevention, or ritual prevention, as it's been phrased before. I'm going to give you the theoretical rationale for the treatment as it's typically done, and also the empirical foundation for that treatment in adults and kids, starting with what's standard so that we know what we're modifying from. So I'm going to spend a little bit of time on this, not too much, but I think these are important things to know because you always think about this theoretically. So if I know what the theory is and I know what I'm trying to do, then I'm going to be able to modify my exposures properly, and some of those modifications are going to be specific to the COVID-19 circumstances, both in terms of restrictions to where we can go and also restrictions as to what we can do. There's some things in exposure that we can't do right now that we would do routinely, and I'll get into those in detail. Okay? So, sort of the foundational paper and theory that underlies everything that we're going to talk about is emotional processing. This is a paper that came out in 1986 in Psychological Bulletin, written by my academic and clinical mentors. And what I would say about this is probably foundationally, fundamentally, the most important thing that we base everything on. Really, really important. I'll break this down. It's an incredibly dense paper. I think as a graduate student at Villanova University, I got it in 1987. I read it probably 20 times before I had any idea what it meant. And I think I spent the last 30 years really letting this govern much of what I do. So let me see if I can summarize it quickly for you, this is Foe and Kozak, emotional processing theory. They posited that two things are necessary for exposure to be effective. The first thing is activation of the fear structure. So what is the person afraid of? And how can I put myself in a circumstance where my exposures are going to tap that fear? I need fear. So that's sort of the irony of the treatment. So people come in, they tell me if they're afraid of something, and I essentially say, good, let's go do it. And I have to find a way to make that palatable. I have to find a way to make that feasible. I have to find a way that doesn't scare people off. So that's important to do up front, but I know I need the fear. So just to be simple about it, if I had a fear of snakes, I need snakes. If I have fear of people, I need people. If I have fear of contamination, I need to go to the contaminants. And that's really important to be able to match up with and make sure that you understand from the patient's perspective what the fear is, what the consequences of confronting the fear are, and if they're engaging, as in the case of OCD, in any sort of active forms of avoidance like compulsion, what function that serves. How is that working to keep you safe? And then we have to confront those situations and reduce and eliminate the avoidance behaviors in order for the exposures to work, because I need to activate the fear. And I'm activating the fear in order to expose people to incompatible information or corrective information. So if I bring you to treat your dog phobia and I bring in a dog that then viciously attacks you, that's probably not a very good exposure. So I've just showed you that your fear is warranted, so I don't want to do that. I want to expose you to dogs that probably won't viciously attack you. And when I expose you to dogs or pictures of dogs and the dogs don't attack you, it provides you with an opportunity to get incompatible information. So I was afraid if I were in this room with a dog who was unleashed, she would viciously attack me. She didn't. And now I gradually expose that person to maybe bigger dogs or closer range to the dog. And over time, I'm going to hopefully see that I've exposed this person to corrective information. So that's the first thing. And I think that what we need to make sure that we're doing is we're properly exposing person to the fear itself, and that when I set up my exposures, it provides them an opportunity to see that things aren't as bad as you thought. You handled it more effectively than you thought. The bad things you were afraid of, if you were afraid of any, didn't come true. And we don't do that exposure once, we do that exposure repeatedly, again and again in different contexts, so as to really drive home the point that the thing you're afraid of, in fact, is not going to happen. Okay? And I'm going to see that that's occurring when I get what we call this between session decreases in fear. So if I do the dog exposure to the same dog every day for 2 weeks, at the end of 2 weeks, I would fully expect that you are used to that dog. And that's great. I want to get you used to other dogs as well. And so I'm going to make sure I'm generalizing my exposures to multiple contexts and multiple dogs in this case. And what I'm also looking to see is, did I change your thinking? So did my exposures and the things I set you up to do, did they result in a change in what Foe and Kozak called evaluations, but really we mean cognitions? Did I change your thinking? Do you now think that when I leave my house, if I don't check repeatedly, I come home at the end of the evening, no one has burned it down? So if I leave my kitchen and I'm afraid that if I don't check the stove, I'm going to leave the stove on, the house is going to burn to the ground. If I come back to the kitchen 6 hours later and the stove is off and the house hasn't burned down, even though I didn't check, that's exposure to incompatible information. And then that's going to put me in a position where when I do that repeatedly, it's going to get easier and easier for you to see that the fear was unfounded. So that's basically what Foe and Kozak are talking about. It's complex, but I'll walk through it as we go. Now, there's an easier way to put this. And this was a comment from my own daughter, who's now a graduate student. She's 24 years old. But back when she was 6, she was always incredulous. And I think she was born skeptical. But she was incredulous as to why, in this particular case, I needed to spend 3 days at a workshop teaching people how to do exposure treatment. And the reason she was upset is because I was going to miss her soccer game. And this kid played 6-year-old soccer like it was the finals of the World Cup. So she was very upset I was going to miss the game. And so I'm leaving the night before, getting myself together. And she says to me, legitimately, she says, so are you telling me that it's going to take you 3 days to teach people what you know? Which was no compliment. And I responded naively. I said, actually, it is. It's quite complex, and it is going to take 3 days. And then she said to me, she said, no, it shouldn't. Said, if you said it in one sentence, then on Friday, you could get it over with, and then you could come back and you wouldn't miss my game. And I got curious at that point. I said, well, what sentence would that be? And this is her sentence. And honestly, I think she did a pretty good job of covering and summarizing FO and COSAC. So you do the thing you're afraid of, the more you do it, the easier it gets. She's right. Provided that you're exposed, and there's all sorts of caveats, provided that you do the exposures correctly, provided that you generalize them, provided that you use multiple stimuli in multiple contexts, but essentially she's right. So when the thing that you're exposing to is not inherently dangerous, and you do exposure to it and it goes well, or it doesn't go badly, I guess is another way to put it, then you learn something. And what you learn is that this thing I was afraid of, or this circumstance I was afraid of, or this person I was afraid of, maybe I shouldn't be. So that fundamentally is what we're all about in the treatment of OCD. We're trying to expose people to corrective information and give them this opportunity to see that the thing that they're afraid of gets easier as they continue to do it. So that's kind of as much as theory I want to get into, but sort of fundamentally that's where we are across all of it. Okay? And in terms of evidence, we have extensive evidence. We have 40 plus years of randomized controlled trials, and that's the standard we want, is randomized controlled trials. You're comparing oftentimes a manualized treatment, one that's been explicated in some detail. We're comparing that to either the passage of time, to a wait list, to another treatment. Sometimes in the case of OCD, it's been compared to medications as well. And I want to see how those things do. Randomization is very important. There's a lot of discussion these days about levels of evidence, even in the context of COVID-19. And what I'd say is an anecdote about how somebody took the medication and felt better and did better, that is not a level of evidence that makes scientists comfortable. That's insufficient. Compared to what? Compared to a randomized assignment to pill placebo versus active medication. In the case of these cognitive behavioral interventions, it's against other therapies, against other active treatments. But every one of these interventions requires, every trial you do requires a comparison to a no treatment control of some kind. So that's very important. And fortunately, in the case of OCD, we have 40 years worth of evidence. We have hundreds and hundreds of patients that have been treated. And basically the theoretical foundation is what I said before. Emotional processing theory may be the best way to explain it. We have multiple published meta-analyses, which are basically summaries of summaries and mathematical calculations to look at what they call effect sizes. How effective is this relative to a control? We've got all sorts of review papers. There's a really good meta-analysis done by Lars Ost out of Sweden, attesting to the efficacy of cognitive behavioral intervention involving exposure plus response prevention. I've got dozens of trials, most of which were included in Ost's summary analysis, and basically showing consistently that cognitive behavior therapy involving exposure plus response prevention. Exposure is the part where you lean into the fear. Response prevention is the part where you reduce and eliminate all forms of avoidance and compulsion. That treatment is effective relative to wait lists, relative to pill placebo, relative to active treatments, relative to, interestingly enough, relative to anxiety management strategies, which is interesting. And also alone and in combination looks like it's effective, a combination with medications. Selective serotonin reuptake inhibitors are typically the medications that are used. for OCD and also for other anxiety disorders and for depression as well. But OCD specifically, FDA approval for a number of those interventions, and relatively speaking, looks like they're effective. They're better than placebo, but they're also maybe not as effective across multiple studies as cognitive behavior therapy. But we have treatments that work, which is good. That's the good news for adults. And the good news for kids is we've got treatments that work for kids too. They're the same treatments, essentially. We're taking the adult protocols, the cognitive behavior therapies, and we're extending them down, changing the language, changing some of the nuances of how you do the treatment to treat teenagers and treat older kids and even treat young kids. We've done some studies on young kids. And what I say is we've got now 20 published randomized studies, which again, the level of evidence, Dr. Fauci's out here every day talking about levels of evidence, and he's right. And I'm very comfortable with the levels of evidence for cognitive behavior therapy for pediatric OCD as well as adult. We have a number of studies that have been done comparing, this list is not comprehensive, but it gets to sort of the core ones that have been done, and looks at it compared to medication, looks at it versus a wait list. We have a couple of trials that have done that. We have a couple of trials that have looked at it against relaxation, which again sounds for an anxiety intervention like something that people might even prefer. And yet relaxation doesn't provide me much relative to cognitive behavior therapy involving exposure plus response prevention. Those POT studies in the middle of this slide, pediatric OCD treatment studies, these were done at Penn, Duke, and Brown. And they were relative efficacy versus combined efficacy in the first study. Second study was looking at kids who were already on medication and adding CBT. Adding CBT was better than adding nothing, and also better than adding a short version of CBT. We needed the full protocol. And then we also have studies of very young children. This is Freeman et al., where we basically took the protocols that were effective for adults and then also for older kids and for teens. We modified them to make them more family-based, and we looked at kids ages 5 to 8. And we got very, very good results from CBT involving exposure plus response prevention relative to basically a relaxation support kind of role. And so this was important for us to see. So it's better to lean into the fear than to try to teach kids methods to cope with their anxiety, because I think some of those methods leave stones unturned, and we don't want to do that in the treatment of exposure of OCD. We want to use exposure, confront the things where they live, confront them repeatedly, and provide the kid an opportunity, even kids, opportunity to disconfirm their beliefs. Exposure to corrective information. I thought this would happen, and instead that happened. Okay. So we're going to talk about the essential components of treatment, and I want to make sure this is as clear as it can be, because when we start talking about how we modify in the context of COVID-19, we have to know what we're modifying from. So what are the core things we need in this intervention? There's a few things, and I'd say that maybe the most important leg on this stool is exposure in vivo. So prolonged confrontation with things that evoke anxiety. Go back to my dog example. If you're afraid of dogs, I need dogs. If you're afraid of snakes, I need snakes. But I don't want a dangerous snake that's going to bite me and I'm going to die in 5 minutes. So I want to make sure I'm exposing people to things that are going to offer corrective information. So if I think about contamination, I need to confront the things that I perceive to be contaminated, which we're going to get into as we go here, because you can well imagine in the context of COVID-19, there's a lot of emphasis on things you shouldn't expose yourself to. And so we have to see, especially with contamination, how that fits or doesn't fit with what we customarily want to do. So what we customarily want to do is I want to touch things that you think are contaminated and yet are objectively low risk. And I think that there's plenty of other forms of OCD that are more readily treated in the context of COVID-19 for somebody who's afraid, for example, that someone's going to break into their home if they don't check repeatedly, that I want to reduce the checking and I want to take the risk. I want to see what happens. And I'm not saying leave the door unlocked necessarily, but what I am saying is I want to lock the door once and walk away from it. And even if I have an intrusive thought of somebody coming through that door and murdering everybody in my house, I still want to tolerate the discomfort that comes from that fear and see, let's just find out. So if you lock the door and then you go upstairs to bed, let's see if somebody breaks in. And in all likelihood, people won't. And that'll provide us with corrective information. So we have those sorts of things that we can treat readily. So in vivo exposure basically is confronting the things in reality that are likely to provoke this fear. We have a lot of people, adults mainly, teens a little bit, but adults mainly, who have fears while they're driving, that if they hit a bump, they fear that they might have hit somebody or hit an animal, and that they didn't recognize it, they didn't notice it, and then they're going to get in trouble later. So with that person, the in vivo exposure is driving. So we have people go driving. We sometimes even drive with them, depending on the setup of our clinics. And we are basically teaching people to confront that fear by driving, and more importantly, when they're driving, to reduce and ultimately eliminate any sort of circling back, any checking behavior, any checking in the rear view to make sure that you didn't hit somebody, and have the person basically confront that circumstance repeatedly. You can do that by driving, okay? Imaginal exposure, I'm going to tap it into what I just said. So imaginal exposure in that situation is thinking about the worst case scenario. So basically writing a script. And the script is going to be, what are you afraid of? So if I touch this, or if I drive my car and I don't check, what am I afraid is going to happen? And the idea here is essentially that if I commit to a script, and I commit to memorizing a script, and I commit to confronting it repeatedly, the 400th time you read about yourself having run over somebody is in all likelihood going to be easier than the first. Any of us who enjoy horror movies know full well that if you watch The Exorcist 100 times, for example, that it's not nearly as anxiety-provoking as it was the first, because you know what's going to happen, and you also get an opportunity by doing these scripts to realize this isn't real. There's a difference between the movie and the reality. And so I want to get you to be exposed to that script again and again and again and again. We have a lot of patients who are afraid that harm is going to befall their loved ones if they don't engage in their tapping compulsions, as another example. And so an imaginal exposure for that case would be, tell me the worst case scenario of you not doing your tapping and your loved one either dies or gets very sick or gets hit by a car. And I want to go through that again and again and again. Because the idea of somebody getting hit by a car is not the same thing as somebody getting hit by a car. We want to make sure we teach people the difference between thoughts and reality. And that's part of what OCD is about. And we want to make sure that we're using imaginal exposure for those people who've got feared consequences, that we're using imaginal exposure enough to provide them an opportunity to be exposed to the corrective information that their anxiety will never go away. And imaginal exposure in the current environment, I'll talk about that when we get down there, is very, very important. Because imaginal exposure is something you can do readily, and there's COVID-19 restrictions are not going to get in your way. You can write a story any old place. And then that's going to give me an opportunity to provide, again, an opportunity for exposure to corrective information. Ritual prevention, that's the flip side. So the exposures, both imaginal and vivo, are all about leading into the fear, going where the fear is, confronting it. Ritual prevention, or response prevention, is about changing your response once you become fearful, once you're in that fearful situation. So if I go into a situation in which I'm afraid that something bad will happen and I have to do my compulsions to make sure that it doesn't, ritual prevention means I want to reduce and ultimately eliminate those compulsions or other forms of avoidance that prevent you from seeing that the bad thing wouldn't have happened anyway. A really good example, there's a Penn State professor, his name is Tom Borkovic. He came in once to Temple University and provided a lecture. And Tom comes in, and customarily the etiquette around grand rounds and those sorts of things is people come in their suits. And Tom came in a shirt that could only be described as something that you probably would have seen in the mid-'70s, the old San Diego Padres jersey, in other words. Like a yellow shirt with brown splotches on it. And he goes through the lecture, and he's always a bit of a character. Goes through the lecture, and about halfway through the lecture, he gets to the slide about the superstitious effects of avoidance and worry. And he looks up at the audience, it's a big room, and he says, oh, so I imagine that some of you have noticed that I'm wearing my lucky shirt today. And we all chuckle, yeah, we noticed the shirt. And he says, you want to know how I know that my shirt is lucky? He says, because every time I wear it, I am not trampled by elephants. And right there, you can see that if I think that the shirt's protecting me from being trampled by elephants, as opposed to the probabilities that there aren't any elephants up on North Broad Street and the likelihood of being trampled is remote. It's not impossible, I guess, but it's so low as to be ignored that I'm going to attribute my safety to the shirt. And that's exactly what people are doing with checking. It's exactly what they're doing with mental compulsions, fixing the bad thoughts by having the good ones. Washing compulsions also serve that same function. And so I need to make sure I'm teaching people, while we're doing exposure, we also have to be reducing and eliminating your compulsions. We teach them how to do it. We teach them why to do it first, then we teach them how to do it. There are cognitive methods that are also embedded in these treatments too. Cognitive behavioral interventions are kind of a mix. So I'm paying attention, and cognitive means I'm paying attention to your thinking. I'm also paying attention to your behavior. And in the case of OCD, the behavior I'm most interested in is avoidance and compulsion. So when you get triggered, what do you wind up doing? I want to change what you're doing so that you provide yourself an opportunity to be exposed to corrective information. I'm also going to talk to you about what those fears might be, what the consequences are that you're afraid of if you don't do your ritualizing. So sometimes people will say, I'm afraid my anxiety will never go down unless I do my compulsions. And that, to me, is a testable hypothesis. So what do you mean by never? And sometimes they'll say, well, it'll just be there for the rest of my life. And I'm like, that's fabulous. Let's go find out. That might be a patient who's got an evening off thing, not just right. So they touch something on the left, it makes them uncomfortable, and they feel like they need to fix it or else they'll be anxious forever. So what I want to do as an exposure there is have them touch things on the left, do it wrong, and resist the urge to fix it by touching with the right. I even put this arm to the side so they don't touch anything. And have them see, okay, let's find out, what do you make of this? So we've been here for half an hour. Do you think you're more uncomfortable now than you were half an hour ago? No. Do you think you're less? Probably. Okay. What do you make of that? Because you told me an hour ago that you were going to be anxious forever. And then the patient might say, well, I guess maybe I was wrong. Okay. Fabulous. Well, let's do that a bunch more times and see if we can challenge this idea in multiple contexts. So there's some cognitive pieces that we're going to come in, and certainly in the case of the person afraid of folks breaking in, when they don't get broken into, which almost invariably is going to be the case, I'm going to be able to provide them with some corrective information there too. It wasn't necessary for you to check repeatedly to keep your family safe when in fact the door's locked and no one broke in anyway. And you didn't have to spend half an hour, 45 minutes, send somebody else downstairs to check too in order to assure that safety. You're fine anyway. That's what we're trying to do. So the components that are kind of core to the intervention, exposure in vivo, imaginal exposure, both of those are about leaning in, and then response prevention, which is changing the way you respond when you're anxious, and the cognitive methods to sort of clarify what it is that we're learning here. Okay? So that's what we're doing in pretty much every one of these interventions. Okay. Now, the younger the kid, the more likely it is I'm going to face some challenges here too. And I think compared to adults, but I think especially with the younger kids, kids have more difficulty with emotion regulation. So I may need to be more conscious of that when I'm selecting my exposure targets. I need to let them know up front that we're doing this on purpose to make you anxious, and make sure that they understand that, and make sure that their parents understand that, because a kid may get dysregulated when they're doing this exposure, and I want the parents ready to deal with that. And just developmentally, kids may have less insight into the senselessness of their fears. And sometimes the kids just don't have good information. A lot of kids who are afraid they're going to get illnesses that they can't get by touching other people. Some young kids who are afraid they're going to get cancer by touching somebody who had cancer. And sometimes you can head that off at the pass by giving them psychoeducation. There are a lot of kids, though, who have that fear, who all recognize that I can't get it this way. I'm just afraid that I might. And I recognize I can't get it this way, but I'm afraid that I might. That calls for exposure. Let's go find out. Your OCD is barking at you, telling you you can get it this way. What do you say we go and lean into this and see what we get? Okay? Another thing with kids, when treating kids, you've got to know what's going on in the family context. Because the family is often a maintaining factor. So if the parents have the same fear as the kids, then we're going to have some more difficulty in confronting that fear. I can recall doing it was an intake. The kid was maybe 10 and had contamination fear, especially around ingesting things. So they come to the table, they'd take half an hour washing their hands before they could even sit down. And so I'm talking to the family about how we might confront this. And I explained that we were probably going to want them at times to come to the table and eat with unwashed hands. And the mom looks at me. She is shot from the corner of the room. She starts pointing at me. She says, "Not in my house." Which to me instantaneously said, we're going to have some trouble with this treatment because I've got some support for the symptoms going on in the family level. So we had to have that discussion. And sometimes that discussion goes well and you can get families to recognize that your kid's pretty ill with this problem and we need to make some exceptions for the sake of getting them healthy. And sometimes you don't get over the hurdle. And there are times when people decline exposure because they think it's not convergent with their own views. And we run into this with scrupulosity too. I want to make sure that I know, so if someone has scrupulosity, they have a lot of fear that they're going to offend God or commit sin inadvertently or sometimes even intentionally. I need to know what the pastor thinks or the rabbi or the imam. I need to know what's going on in the context in which they're practicing their faith. I need to know what's going on in the family because if everybody agrees with this, I'm going to have a harder time designing exposures to provide them with corrective information. So we'll have to confront that. And in order to treat kids, I really need to know what's the system look like, who supports this, who doesn't. And accommodation in particular, which is basically making the road easier. So, for example, if I have a kid who has a problem, his main obsession is to make perfect choices. And he gets up in the morning and he has to select his clothing for the day. And he's sitting there hemming and hawing, what should I wear? What should I do this? Should I do that? Sometimes parents just make the choices for the kid. So the night before they lay out the clothes, there's no decisions to make. It does get the kid out to school earlier, but it doesn't provide them an opportunity for corrective information. So we're going to need to reduce some of that accommodation in exactly the same way we'd have to reduce compulsions. So I want to make sure that I'm understanding at the family level what kind of accommodation is going on, because 95% of families in the context of pediatric OCD are doing at least some accommodation. And it may be different parent to parent, so I want to also understand that well. And I need to target that in treatment. It's just another form of compulsion we're going to need to confront. You also run into the problem with kids having just generally harder time identifying and explaining what their emotions are than adults typically do. And so if they're having difficulty verbalizing the problem, I might have more surprises I may expect. For example, a kid tells me in the office that they think that touching this particular item would be on a 0 to 7 scale, which we use at Rogers. They tell me it might be a 2. So I said, okay, I plan my exposure around that. And then they touch it and they wind up feeling like it's a 6. So they weren't accurate in estimating how hard that would be. And as a therapist, I want to encourage them to touch it anyway. And if they can manage it without ritualizing, I'm going to reinforce them for it. If they can't manage it without ritualizing or avoiding, I'm going to figure out with the kid, how can we confront this situation in a way that's maybe a little bit easier and gives you an opportunity to get used to it in a little bit more of a graduated fashion. A good example would be this. So let's just say my table is the source of contamination. If I touch the pen to the table and I touch that to the mouse, my question is, do I get some stimulus degradation here? So is the mouse touching the mouse? Now, if touching the table is a 7, is touching the mouse a 3 and touching the pen is 5? It's fabulous. I just made myself a ladder, and I can get the kid who's afraid of touching the table and won't do it to touch the mouse instead. then I get used to the mouse, and I work to the pen. I may work to the bottom of the pen, then to the top of the pen that I know touch the table, and then once I'm used to that, I can work myself back up. You may need to make those decisions on the fly with a kid who wasn't able to accurately guess how anxious they'd be to begin with in doing that exposure. Okay? So, one last comment about treating kids. The younger the kid, the more directive I'm going to need to be. The younger the kid, I'm going to make sure that I'm not using language or terms that are confusing to the kid. Like, I don't think I would say we seek to expose you to corrective information. Like, that's just, some 8-year-old's going to give you a look at that point or just not even understand what you mean. So you need to adapt your language to make sure the kids are picking up what you're putting down, as they might say. And I think greater use of goal setting and reinforcement. Kids, they like to earn stuff. They like to have things that they like. So I'm going to use that sort of incentive base to try to get a kid to do things that are hard. So you're going to basically set up a system whereby a kid gets reinforced for coming to session, bringing the stuff to session you asked them to bring, coming on time, staying, at least trying exposure. I'm never rewarding a kid for anxiety reduction. I want to reward them for effort because I can't control whether or not they're going to be anxious. And I don't want them to lie to me. So I'm much rather be inclined to reward the efforts. And those rewards, you work them out in front with the family. You know, you don't need to make outrageous rewards. The younger the kid, the more those rewards should be immediate. You can also use social reinforcement in the midst of rewarding kids because a lot of kids respond well to that. But in these days, when I'm talking about rewards and reinforcement, I've also got to take into account, which we'll talk about later, the implications of doing this work in the context of COVID-19. For example, one of our standard go-tos here in Philadelphia, we've got the oldest zoo in the country and a really good one, is you do all this work for a couple of weeks and we get you a trip to the zoo. Well, the zoo is closed. And I don't want to say I'm going to take you to the zoo in November because right now it's not November and I may need some more immediate reinforcement that I don't have access to right now. So we got to think about how we creatively modify what it is that we're asking kids to do. Like we may take that zoo trip and put it on hold, but still reward them almost like double bonus coupons. You get rewards now, but you can also, you've earned your zoo trip for when the zoo is open again. We want to make sure we're paying attention to that. With adolescents, my biggest issue with adolescents is respecting their independence, treating them as people who know how to think clearly and can think in their best interests, and rewarding and reinforcing their active engagement in treatment. And so I need to do that by not treating them like little kids. I need to engage them in more kind of adult or mature discussions of risk and assessment of risk. They're more inclined to think about what the consequences of their OCD may be because developmentally that's where they are. I want to get them around that point. I also have to spend a fair amount of time in my treatment of adolescents deciding what role the parent plays. And sometimes the parent is playing a really active role and they're able to be almost like coaches, exposure coaches at home. Sometimes I'd much prefer the parent to be a glorified Uber driver because I want this kid to really own this treatment and I don't want any interference that's going to undo some of the work that we're doing, especially if the parent has some of the same fear that the kid is here to treat. I want to make sure I'm attending to that by being flexible about how much or how little parent involvement was going to be in treatment. Okay? So let's chat about the modifications to ERP. Now that you know what ERP is and what it looks like, essentially exposure is leaning into the fear. Response prevention or ritual prevention is reducing and eliminating the compulsions and other forms of avoidance. And we put those two things together and we're likely to get the best outcomes we can get. And there's a few modifications that are coming in light of COVID-19. First is many of us have moved to virtual forms of treatment. So teletherapy, I'll talk about that. Both efficacy, data, but also kind of the opportunities and challenges it poses. We'll talk about the reduction of ERP opportunities. There's 1 million exposures I would do routinely. I can't do now. Like I would not probably with a contamination fearful kid, for example. I would not send them to our local Target here where we do a lot of exposure. I don't think I would send them to Target to touch the railings and touch all the carpets. That's just probably not what the CDC has in mind. Now, there's things the CDC has in mind that the OCD patients elaborate upon. We can work on that piece. So somebody once told me a couple of weeks ago that they were following all the CDC guidelines, and I said, well, okay, fair enough. I said, how many hand washes is that translating to? And the patient looked up and said, I don't know, about 60. And I've been on the CDC website. I've not seen that you should wash your hands 60 times a day. But you should wash your hands in response to these specific kinds of exposures. 60 is letting the OCD run amok with the CDC guidelines. We can't have that. So we'll talk about that too. There's creative use of other opportunities. The fact that you're in their house is a major, major advantage. And I think that we've seen this in other areas. We've seen this when we're treating people remotely who live in rural areas. Some of this teletherapy has actually provided us with some chances to see that not only is it comparable to in-person exposure opportunities, but actually may be better in certain circumstances. Certainly hoarding. I think teletherapy for hoarding is really more powerful than having somebody bring you a single box from their completely filled up house and have you throw it away over the course of an hour or two. I think seeing what it looks like, seeing what it functionally, where this person is, because I've had many cases of hoarding with adults mainly, not always adults, but mainly, where they tell me that, well, the second floor is actually pretty good. Okay, so when I go to this, I've gone, when I go to the second floor of the house, I open the door and paper is falling over the top of the door. I was like, had I trusted your judgment here, no, this actually isn't very good. And the answer is, well, you can walk around in this room. Like, you don't have to walk on top of the stuff. So this is much better. And if I can't see it, I can't evaluate it. So there's some advantages to me being in the space. I'll talk about that some more. And I'll talk about the special case of ERP pertaining to contamination. This is such a complex issue that we actually have an entire webinar devoted specifically to this topic, but I'm going to try to give you the highlights of that. And some considerations you've got to keep in mind as you're doing ERP. You can't do ERP the way you customarily would in this context. You just can't. It's not responsible. It's not credible. And then obviously if somebody gets sick, you're going to be feeling badly about that. But more importantly, I think you can lose some credibility by saying it's fine, everything's fine. You lose a lot of credibility that way. So you have to take this into account. Okay? Let's talk about teletherapy. Couple of really nice articles here. One is about psychiatric services done via telehealth in the context of psychiatric emergencies. This is the Thomas paper. And basically showing that having a kid seen remotely, as opposed to bringing them straight into the crisis center, provides you with some significant advantages in terms of shortening their length of stay, getting to the right places, not having people escalate when they get there. So it really provides us with not only some comparable outcomes, but maybe some improvements in outcome. It also reduces cost, and it also reduces, I think I said, shortening the hospital stay on the ER side. So that's a good thing. So we have evidence that teletherapy can play an important role. The Hilty paper from Psychiatric Clinics in North America reviews multiple studies with adults and kids across many different areas, and basically shows that relative effectiveness is pretty good, and also maybe even more importantly, well accepted by providers, patients, and even administrators. If we get people on board with this idea, and I must say, I've been doing this for a couple of months now, the teletherapy, there's some aspects of it I think are not only comparable, but advantageous. I'm becoming a proponent of those, because when we go back to how things customarily are, I don't think we want to forget the lessons we learned from using teletherapy in this context. There's some real advantages to it. If I'm doing, for example, I'm doing exposures to a nighttime ritual to a kid going to bed, that's hard for me to do at 3 o'clock in the afternoon in my office. So I think there's some advantages of being physically in the space, and being able to see what they're talking about. Oh, that's the contaminated chair. I can't sit over here because it's contaminated by some kid who sat there 5 years ago. And it's easier for me to see what role that plays in their life if I'm seeing the chair than if I'm forced to imagine it. Okay? And this is another paper, really comprehensive review. And again, both adolescent, pediatric, and adult disorders. They did some studies of adolescent management, clinical management of adolescent migraine, ADHD, pediatric obesity. There's some anxiety, depression studies in there as well, and also substance abuse. And again, consistently across time, teletherapy is providing us with some an alternative way to provide the treatment, and maybe to people who couldn't get in otherwise. And it's been often used in the context of treating rural mental health problems. But now I think one way to think about this is everybody's rural now because they can't get in. So maybe the same methods that are already effective with rural mental health may prove helpful in this context. And I'm finding it to be the case. And obviously we're all going to be gathering data on this as we go to build this literature on how well these work and what kinds of case presentations it worked well for, and what kinds of case presentations have a bigger struggle with teletherapy. Okay? So a few things to keep in mind. Teletherapy requires internet access, the same way that remote school does. So you have to pay attention to what percent of the kids in your clinic, what percent of the kids in your schools have that access. And it sounds sad to consider, but not everybody does. And so we have to make sure that we're not asking people to do things they can't do. And sometimes you may find that, you don't have 6 devices in the house, you have 1. So you have to make sure that you're paying attention to how you schedule your meetings to make sure it's not overlapping with another kid's telecommuting school, because now I can't get the kid to the session that I'm trying to have because there's a log jam of who's using this at home. So I want to pay attention to those things. Don't assume is what I'm saying. Don't assume people have access. Don't assume they have 15 devices laying around their house. They may not. I want to do a dry run if I can. I've been doing this in the context of my own work as well. And generally I've found in the last month or two that people, and I'll tell you this, the people who respond better to the teletherapy and all the technical things that go with it are the kids. Sometimes I'm trying to get a parent session and the parent and I are sitting here struggling, and finally the kid walks in the room and says, "No, Mom, you do this." And the kid solves the problem. The kids are, they're technically savvy and they're more comfortable in some ways with this modality than the adults are. So I have to expect that with adults, it's going to be a little clunky. It's going to feel a little weird. There's ever so slight delay that you have to make sure that you're not, because I think that what that leads to, especially for a person like me who likes to talk, is talking over people. I have to give myself a longer pause to make sure that somebody hasn't already started talking. And I'm learning how to do that. I'm learning how to be more patient in my delivery. And I suppose that'll help me in person as well, but certainly it's been helping me teletherapy to understand there's going to be a little gap. So those dry runs are helpful to know. If I have an immediate back and forth, that's one thing. If I have a delay, I need to be conscious of that. The rules of etiquette, I also would want to talk about. Kid or even adult shouldn't show up smoking, shouldn't show up vaping, shouldn't show up laying in their beds, because this is not conducive to doing the treatment and taking it seriously. So what we essentially say around here at Rogers, we say, look, we're doing a ton of virtual therapy these days, is I want you to treat this as if you're here. So you're in the clinic, pretend you're in the clinic. For people who've already been in the clinic, they know exactly what we mean, which is people should be not wearing their pajamas. They shouldn't be laid out flat on the floor. They should be sitting with their feet on the floor if they can. I'm a little flexible with the kids, but I want certain minimal requirements to show that you're participating actively, and I want to hold kids accountable to that too. Rules of etiquette is an interesting little thing we've looked at in the last month, which is you get a chance to meet the kids' pets when you're doing it this way, and sometimes that's really beneficial. So they've been talking about their cat, especially if they've got OCD, and about the cat, and now I'm meeting the cat. I can do exposures with the actual cat, which is fabulous. But what I don't want is I don't want a session to go an hour long with a kid is paying attention to the dog and not to me. So I've got to balance that. I don't say no pets, no nothing. I want to kind of work that out in real time. Sometimes it's advantageous, sometimes it's in the way. And I need to make, rather than just saying a hard and fast rule of no this or that, I'm going to make sure that we are paying some attention. If I have a shy kid who is going to talk about their dog, and that's going to allow me to do some additional work in getting that kid engaged in treatment, then by all means, bring the doggy in. What's her name? Okay? Attention to privacy issues, and this has come up a fair amount, which is I'm having a session with a kid, and all of a sudden somebody walks by in the background with the laundry. Which probably wouldn't happen in our clinic. Or somebody walks in saying, "What would you like for lunch?" Or, you forgot to put out the garbage or something like in the middle of my session. We want to make sure that all kids and families have an idea that we want to treat this privacy issue as something very important, especially with the adolescents. The last thing in the world they need is an adolescent who thinks that somebody's listening into their session, because then they can't be as honest and forthright with me as they like to be. And if you have an adolescent you're treating who has sexual obsessions or has intrusive thoughts about homicide or about their sexual identity, the last thing on earth they're going to talk about in the presence of a parent walking through with the laundry basket is going to be those issues, and your session is going to be compromised. So you got to make sure you pay attention to that. Also pay some attention to attentional issues, and this is true with adults too, but certainly with kids. If I've got them in a room that's very busy, and I've got them in a room that they're really comfortable, and they've got they got their phone on, they've got friends on another computer, I've got to make sure I'm giving myself the best chance to compete for their attention by minimizing as much of that as I can. It doesn't have to be the basement gulag, but it does have to be something that's not distracting them. Okay? So we have, and this is the reality, we have a reduction in exposure opportunities in the context of COVID-19, but not an elimination of them. This is where we're going to get into being creative and making sure that we're not just assuming we can't do the treatment, when in fact I think we can modify it and continue to do the treatment, which is exactly what we're doing in the system. So the stay-at-home order, probably in place in most municipalities at this point. It's probably a good idea even in the places where the governors have made other decisions. One can make a personal decision to stay at home. One can make a personal decision to take reasonable precautions in the context of a pandemic. I'd recommend that we do that. And so here, one of my go-to exposures for somebody who's afraid of spreading contamination is the train station. We go to the train station, we contaminate the rails as people are going up and down the rails, and now I've spread contamination throughout the entire Northeast region. It's fabulous. Except that, here in the context of COVID-19, A, I don't think the CDC would sign on to that, and B, I don't think I want to expose my kids or my adult patients to that level of risk, nor myself. So I'm not going to be able to do some of the standard things, going to Target and touching the bathroom floor and going to the train station, contaminating the rails and having a pretzel. Those things are probably not wise to do at the moment. We'll have to kind of modify again back to the real world when the pandemic is reduced. But in the end, I'm going to need to make some of these adjustments and making sure that I'm not putting kids at risk or even perceived risk. I don't want to feel like people are thinking I'm frivolous about this. I'm not. I want to follow the CDC guidelines and do reasonable things, but I also don't want to give up on opportunities that may be out there to treat people who are really sick. So we have unavailability of people in public spaces. If I have somebody whose OCD surrounds social interaction, for example, it's kind of hard to find people who are willing to talk to you or able to talk to you or not hidden behind a mask or not crossing the street when you come. So we have those kinds of things that are making it more important for us to plan how we're going to involve other people. And planning how we involve other people, this webinar is a good example. My understanding is there might be 1,000 of you out there. So we have 1,000 people in a room. And my guess is if we had access to that sort of opportunity in the clinic, we would have great opportunity to spread the wealth of exposure in social interaction. So a lot of our patients are afraid they made a mistake or said something horrible to somebody in social interaction. We have 5-minute interaction then we have the person turn off their camera. So now you've done the exposure the same way you might in person. You've said words. Your fear that you might have said something horrible is going to come up, and now the person is offline, so you can't check. So in some ways, that actually might be a better way to do these exposures than some other ways. Because I don't want you following the person down the hall and saying, did I say anything horrible to you in the last 5 minutes? Because that would be a compulsion that makes the fear go down. It's an awkward social interaction, as you can imagine, too. But I want to do these things, and it takes more planning. I need to make sure I've got people available at the time the kid's ready to do these social exposures. Okay? And the driving-related exposures, I drove in here this morning. Customarily, I take the back roads because the Schuylkill Expressway is jammed all the time. And I took the Schuylkill Expressway today, and I think it was me and a bus and maybe one other person. So my driving exposures, ironically enough, when it comes to OCD-related driving, they're going to be harder because I'm not going to have the number of people I'm going to need to make that more anxiety-provoking. When you're talking about OCD-related driving exposures, it's very different than driving phobia. Driving phobia, the highway is usually the top of the hierarchy. In my case, when I'm talking about OCD related to running people over, the highway is the bottom of the hierarchy, customarily, because there's not people walking around. The Italian market here in South Philadelphia is the place I send people because there's usually jam-packed action and people cutting across the street every which way. And that's very fear-evoking for patients who've got this particular presentation of OCD. And these days, I could drive the Italian market, and there might be one person there. So it reduces my chances to work on this, which then switches me, which we'll talk about in a minute, to other forms of exposure I could use that are not affected by COVID-19. That would be imaginal exposure. Okay? And we have work and school restrictions that limit relevant exposure opportunities. A lot of our kids are perfectionistic, and even some of our adults who have to hand things in at work, they don't have to hand as much stuff in. In some cases, they don't have to hand in anything. And so the opportunity for it to be something that, quote, counts, or goes on my permanent record, as we used to say back in the old days, if you're not getting the assignments, then you're probably not going to have much opportunity to work on that. And so we have to find creative ways, and the creative ways I'll find sometimes are asking, like taking practice tests and taking materials from education department and having kids practice on that. We recognize it's not the same exact thing, and it won't go in your permanent record, but still the same process. So it might give us a chance to do some of the same exposure, but the peak exposures of handing in a paper that you worked on is going to be graded by your toughest grader. We may lose that opportunity temporarily. Depends on what the school setting is, whether you've got e-school lined up yet. So we do have some chances to work on things, but there may be some restrictions that make it harder to do. And I think the bottom line is the CDC guidelines are going to limit exposure opportunities with respect to contamination. We do some things we just can't do. Now, you can certainly work on response prevention. You can work on imaginal exposure to the worst case scenario. You can also work on response prevention. So if you wash your hands once for 20 seconds, and whatever the birthday song, or in the local area in Philadelphia, we all do Fly, Eagles, Fly. We do this Eagles song, which lasts about 20, 30 seconds. And so if you do it that long, that should be sufficient. And my language for people around contamination and fear and around response prevention these days is CDC guidelines and no more. That gets me away from the person washing 60 times a day, or who touches the desk in a private area and then touches the desk again and washes twice. Like, this is probably, when I leave here, I may well want to do that, but not in the middle of it. Or if I touch my own jacket, for example, which hasn't been out in 2 months, I think I'm probably okay. That doesn't necessitate a wash according to CDC. But according to OCD, which sometimes supersedes the CDC or tries to, that is at issue. Okay? So virtual communities for exposure. We were talking about this before with social exposure. And certainly we want to make sure that we're being more planful and more mindful. We can't just assume we're going to find people, because we may not. So I want to make sure that I'm building that into my planning as I'm trying to do this treatment. You may well be able to strengthen your interpersonal relationship with the patient. There's a lot of leverage to be had in making them feel like you care about what they are interested in, and that you've met their pets and you know where they're living. I think there's some advantages to it. It can also be distracting. You don't want to spend your entire session just talking about the kid's dog. But at the same time, I think meeting the dog and then saying, okay, so it sounds to me like sometimes your OCD, gets you to worry about it. You might hurt your dog. What I just saw in 5 minutes here was that he seemed to treat the dog really nicely. He seems like a nice dog. So what do you say we do some exposure to the thoughts of hurting the dog? And we work on that. You also see a really good example in our clinic recently, which is somebody who'd been avoiding doing an exposure, an adult, in their, quote, creepy basement. And our therapist recognized an opportunity here and said, oh, we've been putting this off for a long time, and now you're home. Where are you? The patient's like, well, I'm on the first floor. So where's the basement? The patient says, it's down the stairs. Okay, grab your computer. Let's go to the basement. So now I'm bridging this gap between doing exposure at home and doing exposure in session, because the session's taking place in the home. So she sent him down the stairs. He did all sorts of exposure to the creepy basement. And we wound up in a circumstance where something that had taken a long time to get done now got done in a single session, because the therapist was able to use that bridge of being in the person's space and encouraging them to finish that exposure. I also think that this is a great time to work on imaginal exposure scripts with every contamination patient we have, certainly, but also some of our other OCD patients who can't expose themselves as much to their feared consequences in circumstances that would provoke their fear. So I may want to spend a fair amount of time working on imaginal. Imaginal is very important when the patient has a feared consequence of, this will happen if I don't ritualize. It's less relevant when the person's more of a not just right. If I touch it on the left, I got to touch on the right. I'm still going to focus on in vivo with those folks. But imaginal can play a really important role in maybe replacing some of the in vivos that we can't do now, but also providing me an opportunity for the patient to really kind of press down on this. Okay? And I think there's some kind of fun things you can do. Like if I can share my screen, if I'm doing work with OCD patients who have some emetophobia to it, we can be watching the same screens, and we can be looking at people vomit. One thing I would recommend highly that people try is to have people vomit backwards, so you can play the thing in reverse. It's actually it's silly, and it's also a little bit of an easier exposure than having them vomit forward. I could fool around with how much or how little they're going to do that. If I have a tiny little screen versus maximizing the screen, it's also going to change what kind of exposures I can do. So some of those things that we might be facile with in the clinic, we can also now use here in the context of teletherapy. And just basically bring the exposure to where the OCD lives to the extent that I can. That's what we're always trying to be about. COVID-19 poses some challenges to that, but there are ways around those challenges and alternative focus. For example, I think imaginal is going to be really important to make sure everybody's doing for anyone who's got feared consequences. I typically prefer in vivo to imaginal, so I think it's sort of more direct. But in this circumstance where I don't have the opportunities for in vivo and I have plenty for imaginal, I'm going to do more of that. Okay? And these things we've talked about, COVID-19 is going to limit your close contact exposures, the over-the-top ones, eating grapes off the train station floor, which I've probably done 200 times in my life. I probably won't tell the CDC that, but I'm not going to be doing it now. Proper response prevention, hand washing restrictions, again, CDC guidelines and no more, and no more, and no more. 20 seconds. Eagles fight song, and that's it. So re-exposure immediately upon washing and showering. I always require that. So if you're going to wash your hands for whatever reason, I want you to re-expose. In the CDC context we're in now, we got to be careful about what we're doing there. I don't want to necessarily have you touch the bathroom floor. I may give you some other things to expose to, a rag that's quote-unquote contaminated. But I don't want to necessarily have you going back out and putting yourself and other people at risk. And really, I want to make sure that there's a lot of discussion, because I think in OCD, even if it's not your OCD concern necessarily, folks with OCD are going to be concerned about COVID-19. And I want to make sure that I'm spending sufficient time differentiating what's possible versus what's probable. A lot of folks out there are saying, if I get COVID-19, it's the end. I'm doomed. And the reality is this is not bubonic plague. The majority of people who get infected are not going to be symptomatic or only going to be mildly symptomatic. Of those who are mildly symptomatic, some of them are going to be maybe a little bit more than others. Some are going to be more sick. Of the people who get really sick, probably 20% of them are going to require some pretty serious intervention like hospitalization. So we're going to have to pay attention to that as well. Not making sure that people don't assume that they are doomed if they get exposed. Possible versus probable. I use it all the time. How likely is this? And my fallback line with every exposure I ever do is I like your odds, but there are no guarantees. And so I spend a lot of time talking about that sort of stuff in this context and say, look, I'm not saying we should violate the CDC guidelines, but at the same time, let's remember that most people are not going to get infected. Of those who get infected, most people aren't going to get sick. Of those who get sick, most people will be mild. Of most people who are more than mildly sick, most people are going to recover. I don't want to lose sight of that. I don't want to be alarmist. I want to be realistic. I don't want to be alarmist. And I got to model that from my patients. Okay? And if COVID-19 is the primary fear, you can imagine it's going to be really hard for us to treat in this context. We'll talk about that in much more detail in one of these subsequent webinars. Okay? So some crucial elements you're going to be fooling around with, adaptations for kids. Case selection, like I said before, if you have COVID-19 as your primary fear, I don't think this is a great time for us to take that on. The interpersonal context and parent involvement we talked about a bit. I got to balance how much to involve the parent or how little based on making sure the kid's the primary driver of treatment. Psychoeducation, just what I said about COVID-19, but even in general. Hierarchy development gets a little more complicated sometimes in the context in which we're finding ourselves because the middle of the hierarchy might be missing and maybe the top of the hierarchy too. So we got to do what we can do. And exposure activities and how we guide those and how we encourage kids to do them when we're not necessarily sitting with them doing them. So the balance of treatment, it really comes down to developmental issues, and also I need to make sure the kid understands that they're the driver. No one's going to make you do anything. I want to make sure you understand that. And how much or how little screen time for parents, I may wind up doing what I often do in my own clinical practice, which is I spend the time mainly with the kid, unless it's a little kid. Mainly with the kid. I have the kid bring the parent in at the end, which you could still do here via telehealth. Tell the parent what we did, why we did it, what role the parent's going to play this week in helping the kid do the homework. There we go. But there may be families in which the kid can't do all that work as much by them independently. I need that parent more. Okay? There may be arguments and disagreements within session, which you'd handle probably the way you would anyway. But you want to make sure if something gets out of hand, you have an opportunity to call back to parent and say, let's go back over what just happened. And we want to foster independence for all kids, but also attend to those contextual issues and developmental issues. Maybe some kids can't do this so well. And maybe this isn't the time to treat them, or maybe I can take more of this approach of teaching the parent to do what I would customarily be doing with the younger kids. And I need to address sensitive content sensitively. I need to be aware of the fact that people are worried. I need to be aware of the fact that people are mindful. One thing I have parents paying attention to is, are you watching CNN with the refrigerated trucks sitting outside of the hospital? Because if you're doing that and your 12-year-old with contamination fear walks by, that's probably not a fabulous thing that they could have avoided being exposed to. So pay attention to your own watching habits. Pay attention to what it is your kids are being exposed to inadvertently. And your own fears, you got to find a way to manage that without making the kids' fear worse. So I'm paying attention to accommodation even now. I want to make sure that parents are not letting the rising tide raise all the boats, and therefore I'm going to do more to make my kid feel good because it's such a tough situation, and therefore not provide them an opportunity to do exposure. If the parents match the kid in fear, we're going to have a harder time with that. Okay? So I want to address accommodation. That may mean some separate time with the family to say, when it comes to reassurance questions, here's what I want you to do. And I don't want to promise the world. We can't take that trip to Disney World tomorrow, maybe even the Philadelphia Zoo. But we want to put some of those things on hold. You can earn those, but I also need to pay attention. If I'm going to use contingency management reward programs, I need to make sure I'm giving you something that keeps your motivation up. Okay? And I'm going to look at the attention to parental versus child risk of realistic risk of COVID exposures. Some kids I may say it's okay to go out and do this. Some kids I'm going to say probably not. Like, probably wouldn't be a fabulous idea because you're immunocompromised. And I want to attend to the value of more immediate reinforcement versus postponing. I think we talked about that already. And I may need to modify timeout procedures where needed in the home. I don't want to necessarily just give up the house and say the kids can do anything they want. Parents still need to parent, but we may need to make some modifications to how we do this in the context of COVID-19. And ongoing consultation, encourage it. If I've got a kid I'm treating and I want the parents to be able to access me so we can talk about these reward contingency management issues and implementation of any adjustments to treatment we're going to make. And I think I'm where I need to be. Q&A. All right, Michelle, you're back.
Hi there. Thank you, Dr. Franklin. Now it's time to answer questions. And because it's such a large webinar, we do have a lot. If we don't get to all of them, I will send an email out later. The first question is, can you talk about the clients who no longer feel they need therapy because they are in the comforts of their own homes? I'm concerned once restrictions are eased, they will be set back even further.
Sure. Yeah, and for some folks whose fears are primarily outside of the house or bringing contamination inside the house, for example, if they're not going outside of the house, then that is going to be eased. And I think that what I want to do, if that patient's already in treatment, I want to say, here are the things there are restrictions, there are limits to what we can do. I still think we can make some headway on this, and I want to make sure that we're taking every opportunity to weaken the fear, even if we can't do everything that we usually do. We talk about the respite that you may feel, but I want to make sure that you're not. It's sort of like when you. I guess the analogy would be this: when you come out of a cast. So when you come out of a cast, you customarily go from a cast to a boot. And you go from a boot to a brace, and then you go from a brace to no brace. And you're trying to build the strength back up in that particular break area. And if I come out of the cast and do absolutely nothing, I don't walk on it, I don't wear the boot, I walk on my crutches, I never touch the floor, I'm not going to regain that strength. So I want to make sure patients are understanding that metaphor as to we don't want to lose ground just because the world has happened to make it easier for you to avoid. Let's not lose ground. Let's think about what we can do. Let's think about imaginal. Let's think about other ways we can be creative with in vivo at home and put ourselves in the best position when we really need to use this thing. We need to go back to what we were doing that we're better able to do it.
Okay, great. The next question is, how would you help a child come to school non-COVID days who is afraid of walking into the building?
Well, it would depend, of course, on the context. So right now, I think most schools, probably not every school, but most schools are closed. And so if I have a kid who is now fearful of the school, when the restrictions are lifted, they're going to need to go back in. They're going to need to confront those fears. My question is there anything I can do in the meantime that would be exposure, that would be okay within CDC guidelines, that would prepare them for that? So maybe things of school. Maybe even, some of these kids are magical about it, looking at pictures on the website of school or touching things from school that have been in your school, like your books, even though they're home now, they're not in your school. My guess is your books would be a low-risk exposure and yet maybe afford us some opportunity to work on school-related matters. In the end, we're going to try to do this as best we can, and it's in some ways the same as it would be in getting a kid to go back to school who hasn't been in school for other reasons. I may send you when the restrictions are lifted, I may send you to the parking lot. I may send you to the playground. I may send you to touch the outside of the door. I may send you into the empty school if we can get permission to do that. And just basically build a hierarchy and do it gradually so that your first time back isn't with a maximum number of kids coming in at 8 a.m. in the morning. Like that's probably not, that's a bit of flooding, and it's probably more than I want to do with a given kid, because it may increase the likelihood they just avoid it. So can I put some interim steps in there that allow you to do some exposure to school, but not full on, violating CDC guidelines or your community guidelines, and get you ready to go back when the time comes? Because the time's going to come. The time is going to come. We're gonna get through it, and it's going to be okay. But people are going to be bringing some of this residual baggage with them, and if you got a vulnerability to OCD, you're going to have more of that baggage to carry. We've got to get them ready.
Thank you. The next question is, what do I do when a mother is obviously anxious about what I am assigning their child?
Yeah, and I'd say that that's not uncommon. I would probably say that I may know that up front, because before I even get to the point of assigning anything, I've probably met this family and spent some time with them. I've probably described my exposures before. And so I have some idea who's already going to be experiencing some trepidation with what I'm asking their kids to do. But it also may be the case, if I did that evaluation a month ago, and now the parents are heightened, and sometimes you're heightened because of your own personal circumstances. So some parent may be heightened because they have an elderly parent. And so a month ago, when you asked them if these exposures would be okay, they said, sure, sounds great. And now, a month later, they're worried about their parent, they're worried about their neighbors, they're worried about themselves in a way they weren't a month ago. So then I may need to pull that parent aside and say, I noticed your response to these suggestions on our teletherapy session was quite different than it was a month ago. So can you walk me through it? I'll just give them an opportunity to say that this is really hard. If I already knew that up front, then I probably was probably doing more prep to begin with before I got to these exposures. But I want to revisit it. But if a parent's not on board, especially if I'm treating a little kid, if a parent's not on board, your exposures are going to be compromised. And so I want to make sure I spend the time necessary to give that parent a chance to talk through it with me, and for me to talk about possible versus probable, to talk about the benefit to your kid of doing this anyway, so that I don't have the what we call between session non-adherence. As a predictor of outcome in CBT for OCD, it's a really powerful one. So if I give you stuff to do between sessions and you don't do it, it's going to compromise your outcome. And if I start looking at why you don't do it, if one of those reasons you don't do it is because your parents were saying maybe it's not a good idea, or they were overtly saying that you can't, then I need to visit that, because I can't just move up the hierarchy, because the treatment's not going to work. I already see the treatment's going off the rails. I need to get it back on the rails before I continue to just kind of blindly go through treating as I would.
Thank you. The next question is, I live in the Bible Belt. How do I get families to comply with not praying?
It's a great question. And I would say that's a great question in the midst of COVID-19. It's a great question before. It's going to be a great question after. So you've got people who are concerned, and you've got people whose one of their main coping methods is to pray. And what I try to do there is psychoeducation. Super important as a psychologist when you're doing this work, that you don't put yourself in the position where you're opposing somebody's faith. You should never do that. I'm not opposing your faith. Here's what I'm trying to do. I'm trying to get you to see that in your kid's case, the OCD has basically wrapped itself in the cloak of your faith and is asking you to do things that are above and beyond, asking you to do things that are unnecessary, asking you to do things that maybe are more than we need, or asking you to engage in praying rituals that really cross the line. So what I want to try to get people to do is understand that we are trying to, in the best interest of the kid, trying to help them reduce the effect of the OCD, and then get back to practicing the faith and enjoying the fruits of those labors in the way that everybody else would. So I'm in that position a lot, depending on the family, depending on the community. And I think as long as I'm selling it as I'm not telling you to get rid of all prayer. I'm trying to get rid of compulsive prayer. To really split that hair, I treated a Baptist minister once, and she came to my office, and she was erudite woman, very well educated, comes in and she has my brochure. It was back in the day. Had a brochure, and she had underlined something in the brochure. She says, I have to pick a bone with you. So what's the bone? And she said, and this is a woman who had the driving fear that we were talking about earlier. And so she says, here in your brochure, you've made a mistake. Said you've listed praying as a compulsion. So your examples of compulsions includes praying. And I wish to tell you that not all prayer is compulsive. And I said, I agree with you 100%. Thank you for pointing it out. Let me clarify, though, what I mean. If you're praying, and I said, and she was in to do this treatment. We're out to go driving and hit every bump in the city. And I said, if you're praying to reduce the chances we hit somebody, you've crossed over into my territory. That's OCD as the day is long. We need to reduce and eliminate that in order for this treatment to work. If you're praying alternatively for the strength to do what needs to be done, by all means, you go right ahead. So I want to make that distinction, but I also want to make sure that I'm not telling everybody that prayer is bad. Prayer is not bad. If it fits in your life, fabulous. But when you're praying to reduce the chance of contamination, I think it's serving a compulsive function, and we need to separate it so that we're understanding what is faith and what is OCD. If we don't understand that, we're going to wind up reinforcing it, and the kid's not going to get better. Okay?
Thank you. The next question is, what do I do when a patient who I believe is deliberately underreporting their anxiety during exposures, especially during virtual treatment?
Yeah. And I would say that probably is an issue that comes up a lot, even in the context of non-COVID-19 exposure, in-person exposure. But it's harder to deal with because you don't have the same visual information you customarily would. So, for example, I'll give you a little example. I got my hand underneath the table right now. If I'm clenching my fist and shaking, can you tell? It's harder. Now, I may notice I'm watching the water. That's where I'm seeing it. So, but this visual information is really hard to get unless you're sitting right here. So I may be missing literally some white knuckling in this case. I may be missing visual information that is going to make it harder for me to be the one who picks it up. And in light of that, what I'm going to do, I'm going to get ahead of that. I'm going to say, look, teletherapy is fabulous. Yay for teletherapy. There's some limits to what I can pick up when we're doing it. And you understand that if you're doing an exposure and it's too hard and I don't pick that up, then I could be asking you to do the next level of exposure that you're not ready to do. So what do you say we have this agreement? You're the eyes. You tell me if this exposure is too hard. And I understand that you might be reluctant to do that, but I also think that I'm not in the position I customarily would be to help figure that out. So if you can help me with that, I promise to listen to you and to modify our exposures accordingly, because the last thing on earth I would need is for you to be doing something that's too hard that's then going to lead you to ritualize. Because if you ritualize, what's the old phrase about ritualizing, which is the first thing you should do if you find yourself in the bottom of a 6-foot hole is put down the shovel. Ritualizing is the shovel. So if you leave my exposure, you were so anxious, you then go and you wash or you shower or you undo or you pray, whatever the case may be, and I didn't pick it up, then I'm going to come back to the next session and say, okay, well, how did things go? And you might say they were fabulous. Good, let's keep moving. So I'm going to give you an even harder exposure if I didn't see that. So I need you to tell me. You tell me. You have a bigger role in this treatment now, almost as the eyes of the therapy, because my eyes are limited in what I can do. Put it on the patient.
Thank you, Dr. Franklin, for taking the time away from your clinical practice and your valuable insights. We have so many wonderful questions, but we are nearing the end. I'd also like to let everyone know that Rogers is here for those struggling with mental health and addiction, now potentially more than ever. We are continuing to accept patients in both inpatient and residential settings in Wisconsin. And we're also proud now to be offering Rogers Connect Care. It's our virtual option for those who are needing IOP and PHP levels of care. Dr. Franklin, before we conclude, could you please share your recommendations on additional resources for our participants?
Oh, sure. Mm-hmm. I just passed that. So we have a few, some of which have to do with the coronavirus and some of which have to do with the availability of treatments. So we have the CDC website up here. We have the International OCD Foundation, which has got plenty of information about COVID-19 and the context of treating. The ADAA has some more specific stuff as well. And the NIH also has some information that's specific to COVID, but also more generally about how best to access treatment and how best to make use of treatment opportunities you've got now that you may not have had a few months ago. This teletherapy is new, and we've certainly been studying it, but it's an adjustment for clinicians, and I think it's an adjustment that many of us are getting more and more used to. It feels more like your regular day. It's just a much shorter commute.
Thank you. And we're coming close to wrapping up. I just want to remind the participants, if we did not get to your questions, please send me an email and we will respond to those at a later time. This session has been recorded, so it will be available on our YouTube channel and also this link on our website. We also, for those of you who met the required time commitment, you will be eligible for CE credits. You'll receive an email with a link to a mandatory evaluation form. And once you complete that, you may download your CD certificate at that time. We also will have the recording of this webinar available on our website, rogersbh.org. This will not be the last webinar that we are doing. We hope that you'll register to join us next Thursday on April 16th to hear from Dr. Stephanie Eakin and Josh Nadeau, who will be covering ways to modify the delivery of pharmaceuticological interventions for OCD, and some unique challenges of delivering this treatment both alone and in combination with CBT via telepsychiatry. Before we go, did you have any parting words, Dr. Franklin?
Yeah, it's what I said sort of in the middle of it, which is we're all going to get through it. Our patients are all going to get through it. We have some opportunities we want to take advantage of. We have some challenges to make that harder, and it's going to force us to be creative. But in the end, I think we are learning a lot about how to be sensitive in the context of what's going on in the world. And when the world returns, we're going to have to make sure that people are not returning to the new world in taking these avoidance strategies that may no longer be necessary when the time comes. CDC obviously will let us know that. And in the meantime, we do the best we can, and we be kind to one another and keep pressing on.
Thank you so much, and thank you for taking the time out. Thank you to all our participants. We had an overwhelming response, and there is quite a few people on today, so we will be in contact to get all of your questions answered. On behalf of everyone at Rogers, we look forward to partnering with you to help you support your patients. My email is michelle.cowles@rogersbh.org, and we look forward to working with you. Thank you.
Thank you, everybody.